Hi, my name is Tariq Gadar, and today we're going to talk about the physiology and the pathophysiology of the glomerulus. So in this lecture, we're going to talk about everything that goes on in the glomerulus from the perspective of the physiology and from the perspective of the disease. First, let's familiarize ourselves with the glomerulus. So if you see here, this is the parietal epithelium, the parietal layer of the epithelium of the glomerulus. This is like remember, every kind of membrane has its double membrane, it's double layered. Well, the kidney is no different. Its functional units are also double layered. So you have this first outer layer, and then you have this visceral inner layer that's made of podocytes with their pedocells. So notice you kind of have this lining adjacent to the capillaries, adjacent to the mesangium. This stuff in here is the mesangium, the intraglomerular cell, the mesangium. And in disease states, it'll expand and it'll become hypercellular, this region here. But this space here is where the filtration occurs. So you can see that you have blood coming in, right? It comes in through the afferent arteriole. It's going to feed into these capillaries, and then it'll exit through the efferent arteriole, and then this will give rise to the vasa recta deeper in the tubules. What I'm trying to draw attention to is sort of that sequence of blood comes into the afferent arteriole, it enters the glomerular capillary, and after entering the glomerular capillary, has to pass through endothelium, the lamina rara, which is sort of this purple line. It's basement membrane. The basement membrane has 3 layers. Don't worry too much about their individual names, but it's a triple layered basement membrane. There's an internal, a middle, and an external part, and that basement membrane is lined by pedocells, which form these filtration slits. You can see these tiny openings where things can pass through, and we'll talk a bit more later about the properties of those things that pass through. But what are they passing into? The Bowman space. And what's the Bowman space lined by? Parietal epithelium and visceral epithelium. Why am I drawing attention to the fact that there's a parietal and an epithelial? Because in disease states, the parietal layer will proliferate and it'll compress the functional component of the kidney. And you can imagine what the consequence of that would be, because everything here in Bowman space will enter the proximal tubule. All right? So it goes into the proximal tubule, and then it'll loop back up to become the distal convoluted tubule. And what's important about the distal convoluted tubule is that there are cells that are going to sense, they're going to sense the amount of chloride and by extension of chloride, the amount of salt, and by extension of salt, the amount of fluid. Because remember, fluid goes where salt goes. Salt and fluid status are they're synonymous in terms of the body's physiology. So this distal convoluted tubule will detect how much flow is coming through the distal tubule, and then there'll be a chain reaction where it'll communicate with the granular cells, and that'll lead to the release of renin, and renin leads to, and there's a whole other lecture on this that's already up there on YouTube, and renin is going to lead to angiotensin, release aldosterone, and the end result is retaining salt and increasing blood pressure so that you can get an adequate filtration. All right, so there's a chain of events. Fluid comes through the afferent arteriole, it enters the capillary, it has to pass, and then whatever needs to filter has to filter, and that includes salt and water, will go through the endothelium, through the basement membrane, and through the filtration slits. It'll go through the proximal tubule, the distal convoluted tubule, and then into the urine. The distal convoluted tubule will keep track of how much salt there is. In states of low salt, some states prostaglandins. We'll talk a bit more about that in a different slide. But the point is, the macula densa in the distal convoluted tubule are going to sense decreased flow of salt if there's a decreased flow of salt, and it's going to signal the granular cells to release renin. All right. So you have inputs and you have outputs. So the inputs, P represents the concentration of a solute. All right. So let's say that would be a good one that you're going to use often in your clinical career is going to be creatinine. All right, so the concentration of the solute in the serum times the rate of filtration, the glomerular filtration rate. So you take to what extent is stuff being exposed to the glomerulus multiplied by the rate of its filtration, and that's the input into here. Right? You have a concentration of a substance here, you have a rate at which it can pass through, and that gives you your input into the Bowman space. And then your output is the flow of urine times the concentration of the substance in the urine. All right, so when you rearrange this mathematically, you get that the GFR is equal to the amount of the substance in the urine times the flow of urine, right? That's the output. How much of a substance are you peeing out? It's the amount that goes in the urine and the speed at which the urine is flowing. All right, the rate of urine flow. So that's your output, and then you just divide it by this term from the input, which is the concentration in the plasma, and that gives you your GFR. And often we'll use creatinine. All right. So any substance that we're going to use has to be, first of all, freely filterable in the glomerulus. Remember this part of the equation. If it doesn't get through the glomerulus and will never be an input into Bowman space, the term becomes zero, essentially. It has to enter the Bowman space. All right. And it can't be broken down, absorbed, and or secreted in the tubule, because that means that once it goes from becoming a P to becoming a U, right? If once it goes from the plasma to the urine, it can't be broken down, reabsorbed, removed from the urine, because that's a confounder. It no longer becomes a good marker for the function of the kidney. And it can't be created or degraded by the kidney itself. All right, so the tubules can't do anything to it. The kidney can't do anything to it. It has to freely go through the glomerulus, and it can't have an effect on renal function itself. Right? It can't enhance or decrease renal function, because then it'll influence its own clearance. So what are we going to use? We're going to focus on the first two criteria. Is it freely filterable? Is it not metabolically active? The most accepted one is creatinine, because it's secreted by tubular cells. All right, so that's not a problem for the average human being, but then once you're working in the context of chronic kidney disease, you have much smaller numbers, right? When you have a really big number, a small amount of error from the tubular cells metabolize secreting the creatinine isn't a big deal. But when your clearance is going to be really low to begin with, that error becomes a little more problematic. Initially, inulin, which was a type of starch, was used. So if you assume that the numerator is constant here, right? If you keep this constant, you assume that the change in the urine, like let's say you have creatinine, right? Creatinine, we're gonna make the assumption, outside of the context of severe end-stage renal disease, that creatinine is a substance that stays at a steady concentration in the urine, and that the rate of urine flow is staying steady. So if we assume that this is constant, there's an inverse proportionality between the GFR and the concentration of the substance in the plasma, such that as the concentration of the concentration of the substance in the plasma increases, the rate of GFR is decreasing, which kind of makes sense. If creatinine is something meant to be cleared by the kidneys and isn't secreted to a tiny amount by tubular cells, if the creatinine in the plasma is going up, it means it's not being filtered. So there's a logical association with it. And here we can see the actual basement membrane. I'd mentioned we would talk about it. You have fenestrated epithelium. So you have this endothelium, which is a type of epithelial cell. So this endothelial cell is fenestrated. It has these gaps that allow things to slide through. And there's this gel-like coating that covers it. And then there's a glomerular basement membrane, and then you have what I really want to draw the most attention to is the podocytes. You see you have your parietal epithelium, then your visceral epithelium, and here's the Bowman space. And here you have a podocyte, which is a visceral epithelial cell, but it extends a bunch of these foot processes, these pedicels, like you get a pedicure, they work on your foot. These are pedicels, all right? And these pedicels form the filtration slits, okay? They form the filtration slits. And these filtration slits are really important because that's what things are going to pass through and be filtered. And that's how you're not going to lose excessive protein in the urine. This is a big component of that. So in the nephrotic syndrome, which we're going to talk about at length, these are injured and they retract. The podocyte is injured and retracts its pedicel. It's like, ouch, and it pulls back these things here. And that allows a lot to leak through. And the nephrotic syndrome is a leakage syndrome. All right, so in summary, you have an endothelial cell with fenestrated capillaries that allow substance to pass through. You have the glomerular basement membrane, and most importantly, you have podocytes. You have these foot processes, okay? And they form these filtration slits with slit diaphragms. And the membrane is negatively charged because of the proteoglycans, like your glycosaminoglycans, remember heparin sulfates, etc. These are all chondroitin, sulfate. These are all negatively charged. The glycosaminoglycans, the proteoglycans, are are negatively charged, and that keeps anionic proteins out. Remember, albumin is negatively charged. That's why calcium is carried on albumin, and why when you have low albumin, you have to correct for the serum calcium, because low albumin means by default leads to lower calcium, because calcium is positive and albumin is negative. Because albumin is negative, it can't cross the membrane. Why? Because the glomerular basement membrane is negatively charged. All right, so you have a size filter, which comes from the podocytes, right? You see 40 nanometers. You have a size filter, but then the membrane itself, this glomerular basement membrane, is negatively charged, and it keeps out negatively charged things. All right, so in glomerulonephritis, this barrier is disrupted, which allows things to get through. So it's a bit different from nephrotic syndrome, where in nephrotic syndrome, you have damage to the filtration slit, so everything is leaking. In nephritic disease, so when there's some inflammation, you do have some protein loss. It's usually not as much as a nephrotic syndrome, because again, in nephrotic syndrome, you have effacement of the filtration slits. In nephritic syndromes, you have more this process of subepithelial and particularly subendothelial, more than anything else, subendothelial and mesangial, inflammation that leads to damage to the glomerular basement membrane, which allows some stuff to leak through. All right. So particles with low molecular weight, which means they can get through the filtration slit, and they hold their electrons tightly, like water or urea, they get to pass through easily because they hold their electrons tightly. They're not repelled by the basement membrane, and when they get through, they can also get through the filtration slit. All right, because they're small enough. So low molecular weight, positively charged or holds its electrons tightly, gets through easily. So let's consider the Starling forces, right? We're all familiar with this equation. So in the context of the kidney, this isn't going to change because they're fenestrated capillaries and their Kf is set to a certain value, right? A fenestrated capillary has a certain coefficient of filtration. It is permeable. Fenestrated capillaries are permeable to things entering them. So this Kf is going to have an arbitrary value that's not going to change. Sorry about that. Okay. And GFR, we know what that is. We already talked about it. So what is GFR dependent on? Right, we know it's inversely proportional to the to whatever substance we're using, whether it's inulin or creatinine. But it's not the creatinine going up that causes GFR to go down. It's just a relationship we can observe and use to clinically track GFR. Here we're talking about what the actual determinants of GFR are. And it comes down to the Starling forces. All right, so your hydrostatic pressure in the glomerulus minus the pressure in Bowman space. And we're going to revisit this on the next slide with an illustration. Minus the osmotic pressure in the capsule minus the osmotic pressure in Bowman space. So in other words, if there's a fluid pressure that's driving stuff out of the glomerulus and into Bowman space, that increases GFR. As that pressure increases, as the differential here increases, this whole term increases. All right. Likewise, if there's a hypoalbuminemic state, like you don't have that much protein holding on to stuff, etc., this term can also change. So if perfusion into the kidney, so let's do a thought exercise. We'll go one by one. What would happen to the GFR if perfusion into the kidney is limited? I want you to pause, answer in your head, and then commit to an answer in your head, and then compare to what I'm going to say. So if perfusion into the kidney is limited, that means that this term is going to go down because the hydrostatic pressure term is going to go down. GFR is going to go down. And the main consequence of that GFR going down can be pre-renal injury. All right, and we'll talk about that. If a patient cannot urinate due to obstruction with resulting hydronephrosis, if there's obstruction, is there flow of urine? Remember, the GFR equation is directly proportional. Remember that input-output relationship. The flow of urine, right, is important, right? GFR, it's directly proportional to the urine concentration times the flow of urine over the plasma concentration of the drug. But if you don't have output because of obstruction, you're not going to be able to generate the kind of pressure differential, concentration difference, etc. So what's going to happen is your GFR is going to decrease. All right, everything's going to back up and the GFR is going to go down. Additionally, so now let's put that in terms of the physiology up here. So first I wanted to kind of have you see it in terms of this mathematical relationship. Remember, that mathematical relationship doesn't actually explain the GFR. It is not a determinant of GFR. So which determinant would that be? Think about how interconnected. Remember, we said there's input and there's output. You have an afferent arteriole that goes into a capillary, and then stuff gets filtered into the filtration slits and into the Bowman space. Once stuff is in the Bowman space, it goes to the urine. Now, if the urine is backed up, the fluid will back all the way up to the Bowman space. So this part increases. All right. And the perfusion to the kidney being limited, this decreased and that decreased the overall term. In this situation, the Bowman space pressure increased and that decreases the overall term. All right. So the overall hydrostatic term is going to decrease and that leads to GFR decreasing. All right. All right. Since plasma albumin doesn't get filtered when the glomerular basement membrane is intact, we tend to focus on these two terms when we think of the causes of decreased GFR. All right. When we're talking about someone with an intact GBM, damage to the tubules can occur in conjunction with GFR, and then through inflammatory processes make an even more decreased GFR. And inflammation will cause this extracellular matrix deposition, so you get this fibrosis, this mesangial expansion. So in inflammation, all bets are off. You do have changes in the second term. And because the tubules are damaged, they're not reabsorbing as well. So you get a kidney injury that some of it has to do with the glomerulus, particularly in the nephritides, the plural of nephritis, nephritides. And you also get that picture with the tubulointerstitial diseases. All right. So those situations will decrease the GFR, but it's because of the intrinsic damage to the kidney. What we are talking about was sort of the Starling equation. We're thinking more of the post-renal, so when fluid backs up and that causes this, and the pre-renal, so when not enough fluid comes in. So you have fluid that backs up and you have fluid supposed to come in. And that balance will help determine the GFR. All right, that's a determinant of the GFR. So over here you can see the renal corpuscle. And I'm just, again, these are the things we talked about. Note, you have fluid comes to the afferent arteriole, gets filtered into the Bowman space, it goes to the proximal tubule, comes out to the distal convoluted tubule. So everything's interconnected. So when fluid backs up, it backs all the way up to here. All right. So what's the role of the mesangial cells? These guys, all hanging out over here. They're smooth muscles that can remodel the basement membrane. So they have important implications. When we talk about mesangial expansion, that is remodeling of the basement membrane that can affect the size of the lumen, that can be more permissive for infiltration of inflammation. But mainly they're acting in physiological situations. They're just holding the tone. Right? They just maintain the tone, the muscular tone of the glomerulus capillaries. All right? That's their general role. But again, in illness, they do not. All right? So over here, you have the afferent arteriole, and notice that supplies the glomerulus, and the efferent arteriole exits the glomerulus. So your input of fluid, what's going to be filtered is coming from the afferent. And sort of the outflow of fluid is determined by the efferent. The outflow of fluid through the capillaries. And the macula densa, we already talked about. They detect salt, and when they detect less salt, they'll cause renin to be released by the granular cells. All right? So over here, I want you to notice there's a direct proportionality between GFR and renal plasma flow, and that's equal to the filtration fraction. What I want you to focus on is how this is a direct proportionality. If this goes up, so does this if you're keeping a constant filtration fraction. So if renal plasma flow decreases, so does the GFR. And that's going to be important for states like congestive heart failure, for states like a heart attack, where anytime you have poor forward flow, hypoperfusion, hemorrhagic shock, septic shock, when not a lot of blood is coming through the afferent arteriole, that's going to lead to a decrease in the GFR. But you would expect that. because we just talked about the Starling forces earlier. So you can kind of see how we talked about the mathematical observation that lets us use creatinine to track the fact that as creatinine goes down, GFR goes up. It's not that creatinine causes GFR to go up. It's that the natural consequence of an increasing GFR is increased clearance of creatinine. Likewise, if creatinine goes up, GFR goes down. And that's the creatinine going up is a natural consequence of the GFR going down. And why would the GFR go down? If we go back to the determinants, it could be because of decreased hydrostatic pressure coming from the afferent arteriole, which goes hand in hand with decreased renal plasma flow. But that decreased pressure from the afferent arteriole decreases overall hydrostatic pressure, and there's less incentive to push fluid through into the Bowman space. And that leads to a decreased GFR. And then this equation also shows us that there's a direct proportionality between GFR and renal plasma flow. So I think the big takeaway here, if you haven't gotten it yet, is that GFR is intimately tied to the perfusion pressures of the body. So you would not be surprised if later, wink, wink, nudge, nudge, we talk about the importance of maintaining that pressure and that the kidney is the only organ besides the heart and the brain capable of autoregulation. So the kidney tries to keep blood pressure in a very important range so that it can maintain its perfusion pressure. And that's completely independent of all of the other neurohumoral mechanisms. All right? Its capillary beds have the ability to autoregulate, and we'll talk more about that. But why does it have that ability? Because glomerular filtration rate is so tied to renal plasma flow. That flow can't be disrupted or you get an acute kidney injury. So you see here, very high hydrostatic pressure in the renal artery, and as you go through the afferent arteriole, it starts to drop, right? But it's high initially. You have a high perfusion pressure, and that makes sense because the afferent arteriole is what feeds the glomerular capillaries, and if the pressure isn't high enough, it can't push through into the Bowman space. And then over here, the pressure has to stay relatively high in the capillary to facilitate that perfusion, and then boom, it drops at the efferent arteriole. Right, and then as you would expect, it just gets lower and lower and lower. It becomes the peritubular capillaries, which we'll look at in the next slide. Then it goes back to the intrarenal vein and the renal vein. All right. One scenario I want to talk about, just drawing attention to the renal vein. There are a couple conditions I want you to put in your mind. There's renal vein thrombosis, RVT, renal vein thrombosis, which is clotting of the renal vein. There's renal cell carcinoma, which is cancer that can compress the renal vein. And when it happens on the left side, anytime the renal vein is compressed on the left side, particularly in a male, remember that the left testicular artery, the left gonadal artery, the left testicular vein and the left gonadal vein, they drain directly into the left renal vein. All right, so the gonadal vein is a general term that whether you're male or female. But what will happen if someone has renal vein compression, not only does the kidney get affected, and we're going to review why, but also the testicles get affected because the testicle, let's say this is going to drain. Let's say this is the left gonadal or testicular vein. It drains into the left renal vein that comes over this way. All right, so your gonads are here, and they go through the inguinal canal, whatever, etc. The vein comes up through the cord, and then it'll join the left renal vein somewhere over here. All right, and then you have your kidney, your little bean buddy over here, and this would be the left renal vein, and lying on top of the left renal vein. No, I don't want that. And lying on top of the left renal vein is the superior mesenteric artery. Okay, so if you have kidney cancer here, you can compress the renal vein. If you have cancer, you can also have a clot, but there's also situations like nephrotic syndrome. In nephrotic syndrome, you don't just lose protein, you lose coagulation proteins as well. So you're prone to clotting. So what you can see is, let's say someone has nephrotic syndrome, or for any reason they're predisposed to clotting. They have cancer, they have nephrotic syndrome, they have one of the protein deficiencies. You can get renal vein thrombosis, which leads to sort of clotting of this vein, and that backflow affects the kidney and affects the left gonadal vein. So then compression by cancer can do the same thing. And the last situation I want to mention is going to be nutcracker syndrome, so SMA compression. So SMA, superior mesenteric artery compression. So if the superior mesenteric artery compresses the renal vein, it can cause congestion of the kidney, and that backs up into the testicle or the left gonad. The left, not the right. Remember, the right, and most people, drains directly into the inferior vena cava. So Tarek, why are you telling me this? What's so important? Why am I learning about nutcracker syndrome? Why are you telling me this about renal vein thrombosis? Why are you telling me this about renal cell carcinoma? Why do I care what happens to the renal vein? Well, if you get thrombosis and this backs up, who backs up next? The intrarenal vein. And who backs up after that? The peritubular capillary. Who's backing up after that? The efferent arteriole. So you can see that the flow of blood becomes stagnant. You no longer have this differential in blood pressure. All right? And that's not good. That's not good. All right? It interferes with kidney function and leads to congestion of the kidney, which in turn can lead to kidney injury. All right? It's the idea that that this whole vasculature is interconnected. So if everything is backing up and now you have poor flow because everything is backing up, or let me rephrase this. Let's not think of it in terms of pressures. Let's think of it in terms of flow. That's probably a better way to describe it anyways, physiologically. If renal vein flow has decreased, then intrarenal vein flow will decrease, and peritubular capillary flow will decrease, and this will decrease, and this will decrease, and this will decrease. And what did we just say? If renal flow is decreasing in the afferent arteriole, remember our relationship that the GFR is directly proportional to renal plasma flow. So if renal plasma flow is decreased, GFR will as well. So in all these conditions, they're going to have their clinical manifestations like nausea, flank pain, etc. You can have left testicular pain, varicose veins. But you'll also witness an increase and decrease in GFR. And what's that going to look like? An increase in the creatinine. All right, that's how all this stuff blends together. So let's look at some more physiologic relationships between the two arterioles. So here you see the renal artery pressure. You have equal resistances, okay? Equal resistances. And you can see here, assuming that the resistances are equal, you have this baseline of 60. All right, I don't want you to get too lost in what's going on over here. What I want you to look at is these numbers and these numbers, all right? So the resistances are relatively similar. We'll call it 60. The glomerular capillary pressure, try saying that 5 times fast. It stays the same. Now what happens if you increase the resistance of the afferent? If the afferent constricts, you get poor flow in here. Notice how this drops. The pressure drops. And if this is dropping, if PGC drops, GFR drops. Remember our mathematical relationship. It's PGC minus PGS minus PBC. It's the pressure in the glomerular capillary minus the pressure in the Bowman space. So if that pressure cannot be maintained, you have problems. All right? And a clinical situation this can happen in is prostaglandins. So NSAIDs, how do they cause kidney injury? You'll hear it. NSAIDs aren't good for your kidney. They can injure your kidney. Better to use 1, 2, 3, etc., etc. So what they do is that they constrict the afferent arteriole. Prostaglandins will keep the afferent open. That's very important. You must know this. You must know this because you're not going to give NSAIDs to a patient in hemorrhagic shock or in any kind of shock. That afferent is being held open by prostaglandins. If you use an NSAID, it closes. And if it closes, you get higher resistance in the afferent. That higher resistance means less fluid can make it to the glomerular capillary. And that decreased glomerular capillary pressure means less fluid makes it through the filtration slit. All right, so there's consequences to our actions. If you note what happens if you make a higher efferent, though, and this is physiologically very important because angiotensin directly leads to the constriction of the efferent. And note how this constriction of the efferent kind of creates this plug pressure. It's like you pinch here and fluid builds up in here and has to get even more pressure to get through. Okay? So if you pinch this side, fluid can't get into the glomerular capillary and it can't perfuse. If you pinch the arteriolar side, the efferent side, when you pinch that, you increase its resistance, then the fluid, the pressure builds up in the glomerular capillary. And that's important because what was the renin, what led to renin being secreted? It was the salt, less salt being delivered to the macula densa, and that less salt being delivered to the macula densa led to the stimulation of the granular cells, and those granular cells secreted renin, and renin led to the cleavage of angiotensinogen into angiotensin 1 and angiotensin 2. And it was the action of angiotensin that leads to the constriction of the efferent and increases the pressure in the glomerulus, which leads to an increased perfusion pressure through the slit diaphragm. And what does that do as a consequence? It leads to increased fluid delivery to the macula densa. So it's a feedback loop. That absence of fluid led to the angiotensin response that constricts the efferent arteriole, that leads to an increased perfusion pressure to get more fluid through. More salt, more fluid. And you can sort of see the relationship between the glomerulus, and remember the distal convoluted tubule, you have to kind of think about where it sits in that diaphragm. It kind of sits like right here when you look at that cross-sectional view, and then you have like an afferent coming in, then an efferent leaving. That's what we're seeing here. The distal convoluted tubule is here, and you see the afferents right next to it and the efferents right there, and then you have the renin secreting cells here, and then you have mesangial cells all hanging out, and then the rest of it. I'm just going to do green here, and that's like the rest of your glomerulus and Bowman space. So you see here you have the afferent, the efferent, and notice how the efferent really forms the peritubular capillaries, all right? So the afferent, so you have your arcuate artery, you have your renal artery, it gives rise to the arcuate artery, and the arcuate artery is going to give off the efferent arteriole. The afferent arteriole. Remember, there's going to be multiple glomeruli. So this arcuate artery sort of courses through the cortex of the kidney and gives off the afferent arteriole. And you have all these peritubular capillaries, and you see it's a very well vascularized structure up here, the proximal convoluted tubule. And you have your peritubular capillaries, and then they come down and become the vasa recta, the straight vessels. All right. So you have your peritubular capillaries, and that's kind of important because remember, your proximal convoluted tubule has the reabsorption of the vast majority of your solutes. So this being well vascularized to this extent is very important physiologically. And then you have your descending loop of Henle, and you have your blood flow coming down. All right? And you have your vein coming up. So they are constantly draining the interstitium. Because remember, there's the countercurrent multiplier system. What does that mean? As the loop, and we're going to talk about it more on other slides, but I'm going to talk about it once here. As fluid goes, it filters into the Bowman space, which is represented by this, empty, this sort of like cut into the glomerulus. You can sort of see this empty space here. That's the Bowman space, and the fluid will drain into that from the glomerulus and go through these capillaries and drop down. As it comes through here, water will leave. All right? Water leaves. And as water leaves, the more concentrated the interstitium is going to get. Okay? The fluid is going in opposite directions. All right? So some fluid is going down towards the hyperosmolar medullary interstitium. And that's the artery, right? The artery is coming in, and it's going down into this hyperosmolar medullary interstitium, this highly concentrated region, and the other one goes up towards the less concentrated cortex. And right now, we're going to talk about the countercurrent multiplier system. What I want you to put in your head right now is you have these vasa recta that are constantly, there's water and salt coming into the interstitium, and the vasa recta are just scooping it up, right? That's how the reabsorption works, right? While these concentration gradients are being formed, the deeper you go, the more concentrated the kidney gets. Water's coming out, salt's coming out, but then you don't want to just sit around in there because it would never come back to the body. How does it get reabsorbed? It's because of the behavior of the vasa recta, the way they come in and they scoop up the fluid and they take the fluid, they take the salt, and they take it all out. All right, that's important. All right, the loops are next to each other, and the deeper you go down the pyramid, the renal pyramid, the more concentrated the interstitium gets. So the fluid goes in opposite direction. One goes down towards the hyperosmolar medullary interstitium, that's the artery, and the vein goes up towards the less concentrated cortex. So you have aquaporins in the descending limb. So now we're going to talk about the mechanism. See, I told you, it's not, we're going to talk about this multiplier system. We're going to make sure you understand it by the time you're here. People tend to overcomplicate it or oversimplify it. It's very straightforward, but you need to understand the physiology. All right, that's why I emphasize the behavior of those vessels. A lot of times when people talk about the countercurrent multiplier system, they don't really emphasize the importance of having these vessels that are just scooping stuff up. So there's aquaporins, which are pro-channel proteins in the basement membranes in the descending limb that allow water to diffuse into the medullary interstitium. Remember, this is very concentrated. This is very concentrated. So these aquaporins allow water to go down its concentration gradients and into the interstitium. So I'm going to draw an arrow here coming out of the descending limb. That's water going down its concentration gradient through the action of aquaporins. All right? And the vasa recta are going to scoop up the water to return it into the arcuate vein. Okay? The ascending limb has the sodium potassium chloride symporter but no aquaporins, which means on this side, especially the thick ascending limb, you're going to get your salts. All right, I'm not going to write everything out because it'll take a while. I'm just going to write salt. So by the time the fluid reaches the distal convoluted tubule, the salt has been removed from it, and it's a very dilute fluid, right? The salt has been removed and it's gone back into the interstitium. So in situations where the body needs to be holding on to salt, we expect this to be upregulated and we expect there to be a very dilute urine. Physiologically. We won't talk about that in this lecture, but we will talk about the nuances of this later on. What I want you to understand right now is that water's coming out on this side, salt's coming out on that side, and it's being absorbed together into these vessels, and eventually into the arcuate vein, and then that's going to drain, and that's how we eventually reabsorb our water and our salt and maintain our volume status. So by the time it reaches the distal convoluted tubule, the fluid is very dilute. Now, urea is secreted into the interstitium, and it also diffuses with water during the descending portion. So as water comes out, urea is coming out as well, and that maintains the concentration gradient. Right? Otherwise, you'd lose the concentration gradient. So it is this constant flow of water and salt and this constant flow of this vasculature that goes parallel to the limbs that allows reabsorption, and that being dragged away by the fluid, and that allows, this constant concentration gradient to form. But what maintains the concentration gradient? It's the urea. So there's different parts of the countercurrent multiplier system. You have the vessels that supply and drain fluid from it, and by draining fluid, they're also draining salts. You have the thin descending limb, which is pumping the water into the interstitium so those vessels can take it back to begin with, and the ascending limb, which is pumping salts out into the interstitium so that the veins can take it in. And why can they do that? Because they're fenestrated. There's holes in the vasa recta that allow easy flow of water and salt. There's no active process. There's just gaps in those walls that allow the fluid to just flow and be, carried into the capillaries, into the vasa recta capillaries, and into the veins, and into the arcuate vein, and back to the body. All right? But none of that is possible if you don't have a constant concentration gradient maintained by the urea, because the concentration gradient is what allowed water to come to diffuse in the first place. All right? That's the countercurrent multiplier system. One more time, in summary, you have vessels that drain the kidney, the nephron, especially in the medullary region. All right? They're called the vasa recta. The loops of Henle pump water and salt out. So the fenestrated capillaries of the vasa recta scoop it up and take it back to the arcuate vein. In the meantime, the concentration gradient is maintained, one, because of this constant siphoning into the arcuate vein, two, because urea maintains the concentration gradient. All right? That's the countercurrent multiplier system. So let's say we give someone isotonic saline. This will expand their volume, their intravascular volume. what happens next? So looking at this equation, we're dumping in more fluid, we're dumping in volume, we're dumping in perfusion pressure. So you have increased renal plasma flow, increased pressure in the glomerular capillary, and that's going to lead to an increased GFR. Why? Because this is increasing the hydrostatic of the pressure entering the peritubular capillaries. Because the GFR does not increase as quickly as the renal plasma flow, the amount of filtrate per unit volume decreases. And that decreases the oncotic pressure, but we're not worried about that. That's not a big deal. All right. It's just, I just want you to be aware that the GFR does not, while the renal plasma flow increases, when you're doing a sudden increase, like through normal saline, the GFR doesn't keep up initially. So the net result is that there's decreased fluid reabsorption into the peritubular capillaries, but overall you've maintained the perfusion pressure. The kidney autoregulates its blood pressure by constricting or relaxing the afferent arteriole in response to solute flow. This occurs due to the smooth muscles that are stretch sensitive. Remember what we talked about? We talked about smooth muscles that control the tone of the kidney. All right, that's important. They're stretch selective. When they activate, they depolarize and they contract. And it's completely independent of neurohormonal, whether it's nerve innervation or sympathetic innervation can just increase GFR by causing constriction. And renin is a hormonal mechanism, and angiotensin is a hormonal mechanism. But this happens independently. All right. So as that initial renal plasma flow becomes overbearing, what will happen is that the kidney will autoregulate by dilating. All right. So that's what I want you to keep in mind. The kidney can respond and it can autoregulate. If you give someone a sudden salt load, the reason why it's not going to make their kidney go kaboom from the pressure is because it can autoregulate. All right. And that's pretty important for a fluid-oriented organ. And then you have tubuloglomerular feedback. So the increase in blood pressure will increase the hydrostatic pressure and GFR. All right. So let's say we gave someone normal saline. We talked about the autoregulation. Let's think that we're talking about something else now. So you have an increase in blood pressure. You have an increase in hydrostatic pressure and GFR, and that leads to more salt delivered to the macula densa. And that Na, that sodium potassium chloride pump in the ascending lib is on the luminal side of the macula densa, and it's sampling what's in the lumen. And the change in chloride, this increased chloride that's now being delivered, leads to depolarization, resulting in calcium entering the macula densa cell. And adenosine is released, and that binds to A1 receptors and causes constriction of the afferent arteriole. Remember what we talked about. What happens if you pinch the afferent arteriole? You decrease pressure. That's tubuloglomerular feedback. That's saying, okay, this pressure is too high. We're losing salt in here. I don't know if I have the capacity to reabsorb all of this. This is kind of wasteful. Let me intervene. And how does it intervene? That change in the chloride leads to depolarization, and that leads to release of adenosine, and adenosine will cause vasoconstriction of the afferent arteriole through its A1 receptor. Usually adenosine causes vasodilation. This is a rare exception of adenosine causing vasoconstriction through its action through the A1 receptor. So that increase in the afferent arteriole decreases the GFR, and that counteracts your initial increase. So you had two mechanisms. You had autoregulation. So when you give someone saline, you just suddenly inject someone with isotonic saline, they have autoregulation, which will keep the pressure. The smooth muscle will react to that. Be like, pressure's high, let me dilate. All right, assuming you have a healthy system. With smoking, you damage your vessels and all bets are off. Don't smoke. And the other mechanism is the tubuloglomerular feedback, which is, we have too much salt here. I'm gonna depolarize, release adenosine. That'll constrict my afferent arteriole. All right. And like I mentioned earlier, NSAIDs maintain. It's the prostaglandin, thromboxanes, etc., of the COX pathway that maintain this mechanism. So when you provide an NSAID, it causes closing of the afferent arteriole. All right, and that's bad. So if someone has a pre-renal and they already have an AKI, so they have a lack of perfusion reaching the kidney, you're not going to give them an NSAID on top of this, because that destroys really what's the only thing keeping the afferent arteriole open. All right, it sends the sensitivity, it knocks the sensitivity out of whack, and then you end up causing release of adenosine prematurely and even more constriction. It's just not safe. the other thing I wanted to mention pharmacologically is that that apical transporter is inhibited by furosemide. So if you remember, when you want to, so think about what's going on. When you're giving furosemide, you're trying to get fluid out of the body. You want to tell the NAKCl transporter stop. All right. You want it to not be bringing salt back into the body, so you can inhibit it with furosemide, and that prevents salts from coming into the body again, and it forces it into the urine, and that will also lead to what do you call it? Why am I blanking what I was saying? It decreases the salt. So that increase in salt going to the urine means that water is also going to go with that salt into the urine, and you get that excess water out of your body. That's why we use loop diuretics in volume overload states. All right, so this is just a table for your interest of all the different things that can do all the things. With the constrictions, we're not going to go over it. All right, there's other factors like the renin-angiotensin-aldosterone system. Like I mentioned, there's direct sympathetic tone by norepinephrine. It'll decrease pressure in the efferent and afferent, and they can directly activate the renin-angiotensin system, etc. There's some other neurohormonal stuff, but we're not going to go into it here. And this is the autoregulatory range. I just want you to see it illustrated. All right, so to summarize all the physiology we just did before we look at some of the pathophys and then move into the nephritic and nephrotic syndromes, the kidneys have a massive blood flow relative to their own mass. Glomerular hydrostatic pressure is determined by the afferent and efferent arterioles, and filtration is subject to Starling forces. There's a glomerular filtration barrier that is negatively charged and does not allow large molecules through, and control of resistances and autoregulation keep GFR stable. All right, so let's look at some cardiorenal syndromes. All right, so you look over here, you have heart failure. That heart failure leads to low flow. So what happens? You have increased renal vasoconstriction. And remember sort of how you have the afferent arteriole gives rise to the capillaries, and then the efferent, and then the peritubular capillaries. What do you think is going to happen if you get vasoconstriction? All right, remember how autoregulation works and how the renin-angiotensin-aldosterone system works. You're going to lead to vasoconstriction because what's going to happen? The heart's in failure. Remember, mean arterial pressure, and I would recommend you to look it up real quick if you don't remember it. Mean arterial pressure is a product of cardiac output and systemic vascular resistance. So when you have low cardiac output, you're going to have decreased mean arterial pressure, and that applies to the renal artery. And when the renal artery has low pressure, everything's going to have to vasoconstrict, and that vasoconstriction, while it might maintain the perfusion pressure, it'll cut off that blood supply to those peritubular capillaries, which leads to acute tubular necrosis. All right, and the proximal convoluted tubule is a very metabolically active. Remember, most of the reabsorption is happening there. It's very susceptible to ischemia. It's the most metabolic active region. All right. So then coming on here, we have a more elegant diagram. All right, which kind of shows there's increased cardiac congestion, increased right atrial pressure, increased central venous pressure, and the result of all this is decreased cardiac output. And what does that lead to? Renal venous hypertension. You get backing up. All right, stuff backs up because remember the renal vein is eventually going to make its way to the inferior vena cava and drain into the right atrium. But if it backs up from the right atrium into the renal vein, you get increased efferent pressures, and that leads to renal congestion. Remember we talked about what happens. We talked about 3 different clinical cases that all lead to the same thing, that congestion of the kidney. So you get that renal congestion, which increases the hydrostatic pressure, the glomerular pressure, but there's not a good, it's not physiologic, right? So you get this fibrotic process. At the same time, from the other side, you get intra-abdominal hypertension and poor renal blood flow. So, you get this loss of GFR, this loss of urine output, you just have all this stuff going on. And between that and the fibrogenesis and the renal congestion, you get this neurohormonal and inflammatory response with the things listed here, which you should already be familiar with from cardiology. And what's the result of this? Increased effective arterial blood volume, fluid overload, and salt and water retention. So the ailing heart leads to an ailing kidney, and they sort of have this suicidal dance where the worsening kidney function leads to more fluid overload and increased return of fluid to the heart, a heart that is ailing and can't handle what it's being given, and that leads to an even worsening cardiac function, which leads to a worsening renal function, which leads to a worsening cardiac function, and you're really just stuck in this endless loop. And I think this diagram here shows that loop better. You see there's a lot of things that lead to heart failure, and it's interconnected with kidney disease, but what's the bottom line? What's going on in the kidney is affecting the heart, and what's going on in the heart affects the kidney. So really, cardiologists and nephrologists are on the same team, in theory. All right. So I kind of want to point out where all the diuretics act, because I think that's important. We're not going to go into it in detail here because that's for a different lecture. So loop diuretics are in the thick ascending limb. They're going to target the sodium potassium 2-chloride transporter. Thiazide diuretics are going to target the luminal sodium chloride cotransporter. This is also what angiotensin upregulates, this transporter, and thiazides target it. And then you have potassium sparing diuretics that'll act in the collecting tubules. All right, but that's a different lecture. So nephrotic syndrome is the destruction or the loss of the glomerular filtration barrier, like we mentioned, and then the retraction of the podocytes. And you lose a lot of protein, at least 3 or 4 plus. And you'll see hyperlipidemia because you lose fat in the urine, and then so you see these fatty casts sometimes. And you'll lose fat in the urine. You get these oval fat bodies, is kind of what you see on an exam. And you'll also get hyperlipidemia in the serum. I don't know if this is exactly how it works, but think of it as like lipids being lost in the urine, and then the body tries to replace that by by causing hyperlipidemia in the serum. All right. So I like this quote. I like the way it's phrased here. The common structural finding in all nephrotic conditions is prominent and extensive damage of the glomerular visceral epithelial cells manifested by diffuse simplification or effacement of foot processes, also referred to as fusion of foot processes. Because the primary target of the injury is the glomerular visceral epithelial cell, the glomerular visceral epithelial cell, the podocyte, these conditions can be considered as primary podocytopathies. So all of nephrotic syndrome is really doing the same thing. So this is the first condition. It's called minimal change disease. Notice there's nothing abnormal in the histology. You wouldn't see anything wrong. The changes are minimal. They're minimal change disease. And it's common in the very young. You can see here you don't really have neat podocytes anymore, neat pedicels. Here's your podocyte, but you don't have neat pedicels, right? It's very fused together, not well demarcated, certainly not a filtration slit diaphragm. It's common in youngsters. What you'll see often in older patients, which has a similar clinical presentation, is focal and segmental glomerular sclerosis, which can be primary, secondary, or adaptive. And this, unlike minimal change disease, which usually doesn't cause anything, this results in renal failure. And there's sort of 3 tracks that can cause this: focal and segmental glomerular sclerosis. So notice on light microscopy on the H&E stain, you have this focal and segmented sclerosis, the sclerotic, fibrotic configuration of the glomerulus. And you see these structures, these bumps. All right. So you see these coarse deposits of IgM and C3, and that's if you do a immunofluorescence stain, you'll see that. Now, what you're going to do is you're going to stain, and you're going to see a couple things. If you see a fine dusting of IgG over the podocytes in this diffuse podocyte injury, that's a primary process. All right? That's directly, that's direct immune damage to the podocyte. Primary focal and segmental glomerular sclerosis. Now, if you don't see IgG deposits, that means there's a specific podocyte injury. So if there's a family history of this stuff, then it's a familial podocytopathy. If it's a slowly progressive proteinuria in the context of prior kidney disease, that's secondary, glomerulosclerosis. If it's happening out of nowhere, it's usually going to be an autosomal recessive podocytopathy. Now, if there's underlying glomerulonephritis, so if there's an inflammatory process happening with possibly no podocyte injury, and if so, it's limited, and in the past the patient has had active glomerulonephritis, this is just focal and segmental scarring as a result of the nephritis. So notice how there's sort of an overlap. You can have a familial thing that's not because of Ig deposits, right? There's no deposits of immunoglobulin, and that's going to be either adaptive because of current kidney disease, or it's going to be primary, but because of, it's not primary as a classification, it's just genetic. If you do have immune complex involvement, then that's the primary idiopathic focal and segmental glomerulosclerosis. If you don't have, a genetic predisposition and there's no genetic thing going on and there's no prior kidney disease, and you have these, it's not primary process, and you have this medical history of glomerulonephritis, et cetera, it's just focal and segmental scarring. It's the scarring caused by the nephritis. All right, and we'll talk about nephritis down the line. Right now we're focusing more on nephrosis, which is what's happening. Like if you draw a line here, this is the stuff that we're talking about with nephrotic syndrome, all right? So again, you can see sort of the appearance of the basement membrane. You can see this lesion here. There's just a fibrotic process. It's a sclerotic fibrotic process. It's focal, it's happening in a specific part, and it's segmental, and it's affecting a segment of the glomerulus, and it's sclerotic. It's a focal and segmental glomerulosclerosis. All right, and I just want you to relate that to what we know about the structure of the Bowman's capsule. So remember, the capillaries normally are open, and in this disease state, in membranous glomerulopathy, all right, this is membranous nephropathy. So this is immune complicated, immune mediated, and notice that the capillaries are open. This is an open, so these capillaries, all these open white spaces that you see here, all right, here's a capillary, there's a capillary, there's a capillary, etc. And you can see that if the membrane is thickened, all of it is just thickened, and on the light microscope you don't see pedicels, you see these spike and dome complexes. All right, all this is happening because of on-site formation of immune complexes in the subepithelial space of the glomerular basement membrane. Some say there's a circulating antigen and it gets deposited. Some say that it's the phospholipase. Over half of autoantibodies in these patients are to the phospholipase A2 receptor of the glomerular epithelium. So it can happen in situ. It can happen, and usually whenever there's two competing theories, usually it's like a mix of both. So is there a circulating antigen? Yes, that can cause it. Can it happen in situ? Yes, that can happen. The big overarching point is that it's a subepithelial immune complex disease. All right, as manifested by the spike and dome appearance. This is all subepithelial. This is the epithelium. This is your endothelium here. All right, this is the lumen of the capillary. This is the endothelial cell. This is the capillary, the empty space in the capillary, its lumen. And then here's the glomerular basement membrane, and here's the epithelium. And notice that it's subepithelial inflammation over here. All right. And so there's some other causes of membranous nephropathy, penicillamine, captopril, gold, NSAIDs, underlying cancers, lupus, chronic hepatitis C and B. So C and B hepatitis are associated with immune complex disease. It can be cryoglobulinemia, it can be membranous nephropathy, etc. Syphilis, schistosomiasis, malaria, other autoimmune disorders. And really what differentiates membranous nephropathy from the other immune complex disease is that this is in situ immune complex formation in a subepithelial. It's subepithelial in situ. All right. One thing before I forget, HIV, and this is particularly important for step 2, probably less so for step 1, but HIV is a direct cause of membranous nephropathy. It can directly affect the podocyte. It damages the podocyte specifically. And the higher your HIV load and the more advanced your disease, so as your CD count drops and your HIV load goes up, you're more likely to develop focal and segmental glomerulosclerosis. Not membranous nephropathy, but focal and segmental glomerulosclerosis. I just wanted to throw that out there before I forget. So HIV directly injures podocytes and causes a focal and segmental glomerulosclerosis picture. All right, so here are all the different places that deposits can go. So you can have subepithelial deposits that can be seen in post-infectious glomerulonephritis. When we talk about the nephritides, here we're talking about a lot of the nephritides. And then, we have membranous nephropathy as well, yes. But again, going back to nephritides, you can have subendothelial. So over here, it can be along the endothelium. It can be mesangial, right? Or it can be directly on the basement membrane. So where can things deposit? Where can they deposit? It's going to be either on the basement membrane, or it's going to be along the subendothelium, or in the mesangial region. All right. And subepithelial, it's usually in situ. Now, lupus can cause both. It can cause a membranous nephropathy and a diffuse progressive glomerulonephritis. So it causes because immune complex is immune complex. With lupus, you can get them here, you can get them there, you can get them there, you can get them everywhere. In the glumen, out the lumen. Lupus is lupus. All right. So it can present as both. Now, again, going back to the in situ subepithelial deposits, the deposits form in situ, and the theory is they're either forming due to, again, like I mentioned, there's either a circulating agent or it's an epithelial target antigen. The point is, at the end of the day, the complexes form there in the subepithelium, and the nephrotic picture occurs because the complexes stimulate production of the basement membrane, and that leads to the spike and dome appearance. Pure subepithelial disease is typically nephrotic. Why? Because the complement is contained to a site not in contact with the immune system. If you think back to that slide, the subepithelium is not related to the capillary lumen. It can't recruit the immune system. So even if you resolve the injury that caused this to begin with, the proteinuria can take a long time, even years to resolve, because the immune system can't come and clear it, right? So versus you get subendothelial and mesangial deposition. So you have the lamina rara interna. That's the part of the basement membrane closest to the endothelium. That's why it's called subendothelial. It's just easier to say subendothelial than the deposits of the lamina rara interna. No, you just say subendothelial deposits, because that layer, the lamina rara interna, is really right next to the capillary lumen. So you can imagine those subendothelial deposits are pretty good at recruiting immune activity. The mesangial deposits can get away with it a bit because they might not necessarily be right next to the capillary. You'll still get nephritis, but the subendothelial deposits can really cause a problem. All right, because C3 and C5a, remember, you have antibodies, you have immune complexes, and the formation of the immune complexes lead to cleavage, and you get the classic alternative pathways, etc. And C3a and C5a cause chemotaxis. So if you're close to the endothelium, you have all this inflammation coming in, and where there's inflammation, there's clotting problems. You can get thrombosis of the vessels, and that also contributes to the inflammation, even further. You get, when the moment the endothelium is involved, on top of all these factors, once the endothelium is involved, you get it's called an activated endothelium. The inflammatory endothelium expresses a lot of adhesion molecules. Remember, the leukocytes have adhesion molecules, and that's how they sort of bind to the capillary and then come through the wall to enter the tissues. So that what'll happen is you get activated capillaries, activated endothelium because of the subendothelial deposits. They're causing inflammation of the endothelium. The endothelium becomes activated, and it expresses adhesion molecules, and they'll sort of grab the white blood cells and bring them in. And then, that's mediated by TNF-alpha and IL-1 and CF5A, leukotrienes. All the cytokines you learn in pathology are going to activate the inflammatory cells. So the inflammatory cells get activated, the endothelium is activated, and that leads to bad. And that's called diffuse progressive glomerulonephritis. So I want you to notice the hypercellularity of the tufts and how the white blood cells have infiltrated. I want you to notice the red blood cells. That's why we don't get blood with nephrotic syndrome. We're all the way up by the, we screwed the filtration barrier, and there's going to be kidney injury and all sorts of stuff and possibly renal failure, but we're not going to get blood or an active urine sediment. The reason we get the active urine sediment in the nephritic picture is because you have damage to the vessels. This mess is happening where things are draining from and in contact with white blood cells and red blood cells and all this stuff. So you get these red blood cells in Bowman space, and it's going to lead to casts forming in the tubules. And then you'll see those on your analysis. So it's usually going to affect all the glomeruli, and you can sort of see how it's just diffuse. It's a diffuse glomerulonephritis. I want you to notice how different the glomerulus looks. You don't see really a well-defined Bowman space at all. You see a big mesangial expansion. You see a lot of sort of basement membrane that's been laid down. That's the mesangial expansion. All this pink stuff that wasn't there before, that's here now. I kind of wish I put a normal glomerulus here for you guys to see. But also you have this infiltration with polymorphonucleocytes, all right? So that is the hallmark of glomerulonephritis. And on the electron microscope, you can see the scattered deposits fluorescing. And notice it's scattered. In Goodpasture syndrome or anti-glomerular basement body disease, anti-glomerular basement membrane antibody disease, you'll see sort of a bunch of IgG fluorescing in a very neat like ribbon all along this wall. What you see here is a bunch of scattered complexes. All right, and notice that each of these circles is sort of like a capillary, and you can notice that it's subendothelial, right? It's close to the endothelium. It can bring in the inflammatory infiltrate. All right. While this large hump doesn't cause the disease, it can help you spot it on electron microscopy. What we're more concerned with, so this is a polymorphonucleocyte. This is all a white blood cell. Don't let this like fool you that there's something going on here. This is just remember, you take a section, you sort of slice through tissue, and here you've just sort of sliced the nucleus at two different, at a certain level where it sort of was shaped like this. The nucleus might have been like sort of crescent shaped. So when you cut it here and you look in, you're going to see this part and this part as separate, right? So you just kind of cut the nucleus at two different levels. So you have this artifact here, but this is all a polymorphonucleocyte. And over here, we have, these are the deposits that these are the subepithelial deposits. All right, the subendothelial deposits, right? Here's our glomerular basement membrane. Here's our epithelium. You have a subepithelial deposit. We're not too concerned about that. What we're concerned with in this disease state is all of these, the subendothelial, the ones that are on the part of the glomerular basement membrane that's continuous with the capillary. And note how a polymorphonucleocyte has been recruited to this site. Why? Because it's in close proximity to the capillary. The capillary is endothelium and it's activated, et cetera, et cetera, et cetera. Why is it activated? Because of the complexes. So when this occurs with persistence, chronic inflammation will lead to membranoproliferative disease. So we talked about the sort of the mesangial expansion. So I want you to think of like this chronic inflammation, this fibrosis, this mesangial expansion. And that's kind of what we saw on the last slide. We saw the results of the chronic inflammation. And you'll see mononuclear cells. On the last slide, it was more, you saw a polymorphonucleocyte. But what you'll see is later on, especially later on, is going to be mononuclear cells. And we'll look and we'll see how it's going to be a bit different on the next one. So this state, when you've really had non-stop mesangial expansion, I mean non-stop for a prolonged period of time, with lots of inflammation and fibrosis, what happens is that a second membrane is formed by the activated endothelium. So you have immune complex disease that displaces the endothelial membrane, and then you have a second membrane that forms. All right, and that you have one membrane and then a second membrane. And that's going to lead to the development of of this double wall, this tram track appearance. And you can see that here. So I'm just going to drink water for a second. And you can see that here. You can see the glomerular tuft, you can see it's hypercellular, you can see the mesangial expansion, and you can see the tram tracking, this really thickened capillary wall, right? Everything is just so thickened. And you can see it here. It's very thickened. You have some fluorescing deposits. All right. So there's a couple patterns for diffuse proliferative and membranous proliferative pattern of glomerular injury. If it's C3 and C1q, actually at this point you probably don't need to know this too deeply. What I want you to think of, you have your IG, right? Your immune globulin mediated disease. All right. So you look on light microscopy and you're going to see this stuff. All right. What's going on up here? Okay. And you can have either polyclonal or monoclonal immunoglobulins. All right. If it's polyclonal globulins and they have this subendothelial mesangial picture, this is immune complex disease, right? You have different immunoglobulins, et cetera, et cetera. This is all, and the reason, and it's polyclonal. The importance of it being polyclonal immunoglobulin is that it's coming from immune complex disease that's a result of autoimmunity or infection, versus if it's monoclonal, it means it's coming from like one B cell, right? One B cell, one plasma cell dyscrasia. There's something going on that led to this, all right? And if there's no immune globulin, and it's only C3, so you want to think about dense deposit disease, all right? And don't worry too much about that right now. The bigger point I want to illustrate is that if it's polyclonal immunoglobulin, for it to be polyclonal, it just means it's the body's physiologic response to inflammation, whether it's from autoimmunity or infection. If it's monoclonal, it means all the immunoglobulins are coming from one source. So your source that's causing this deposition disease, got to look for it. If it's not immunoglobulin related, it could just be fibrin. All right, and that's more of a thrombotic picture. It's like a vascular disease, and we'll talk about that in a different lecture entirely. And if it's not if it's not immunoglobulin and it's not vascular, it's a problem with the C3 convertase. It's usually an antibody directed against the C3 component. It's directed against the alternative pathway. So that dense deposit disease and that C3 glomerular nephritis, and they'll present as hypocomplementemia and antibodies directed against the alternative pathway that would not have immune globulins involved, but you'd have hypocomplementemia. All right, so you have to differentiate that from lupus, because you'll get hypocomplementemia in lupus, but you'll also get IG. You'll have immunoglobulins. All right, that's important. You'll have polyclonal immunoglobulins in lupus, but you will not have polyclonal immunoglobulin. You won't have immunoglobulins in dense deposit disease. That's sort of where the art of the differential diagnosis comes in. Now, you have to consider paraprotein diseases like myeloma. So aggregates form in the extracellular matrix of kidneys, and you can do this heavy and light chain staining on immunofluorescence. Chronic thrombosis. We'll also talk more about myeloma because it has some implications for the tubules of the kidney when we do our tubules lecture. Chronic thrombosis, and we'll talk about the vascular causes of disease in a different lecture. And then when infections of the mucosa are happening with this picture at the same time, so what happens is someone gets like a upper respiratory infection or GI infection, and within 1 or 2 days they have this nephropathy. Consider IgA nephropathy. Remember, IgA is the the antibody that's active in the mucosal surfaces. So when you get these mucosal infections, you have increased IgA, and you can get an IgA nephropathy. So it makes sense that it would happen with these mucosal infections. All right, it can be associated with Henoch-Schönlein purpura, ankylosing spondylitis, celiac disease, dermatitis herpetiformis, IBD, cirrhosis, etc. Okay. So let's say we get, I like this table from UWorld, that's why I stuck it in here. Let's say we get the glomerular nephritis, we want to evaluate the serology, okay? We have dysmorphic erythrocytes and erythrocyte casts when we look at the urinalysis, and the serum complement is normal. That means if you have glomerular nephritis and the complement is normal, you don't have complex mediated disease, it means it's antibody mediated disease, right? Because complex mediated disease lowers your complement. If it's not happening because of immune complex, it's direct antibody-mediated disease. And that's what's going on in Goodpasture disease. So you get these anti-GBM antibodies to the alpha-4 collagen, alpha-4 chain to the type 4 collagen in the glomerular basement membrane, which is also shared with the lungs. So you'll get lung disease and kidney disease. They don't have to happen at the same time. It can start in the lungs or it can start in the kidney, but you get this lung and kidney picture. You can get this lung and kidney picture eventually because it's the same basement membrane antigen. And you also have the pauci-immune glomerulonephritis, the ANCA, like the Wegener's, etc. Although we're not supposed to call it that anymore. The granulomatosis with polyangiitis, the ANCA-associated vasculitides. But we'll talk about those. Now, if you have low complement, you need to consider all the diseases that cause immune complex disease because that consumes complement. All right, immune complexes consume complement. So that means lupus. It can be cryoglobulins, hepatitis C, or just cryoglobulins because of another autoimmune disorder. Infection related, which you have staphylococcus associated, endocarditis associated, and then you have post-streptococcal. So you might be asking me, Tarek, how do I differentiate between IgA nephropathy and post-streptococcal glomerular nephritis nephropathy? How do I tell the difference? If they're both happening with respiratory infections, the key is the timeline. The post-streptococcal glomerular nephritis are because of ASO antibodies, anti-streptolysin antibodies. And that's happening weeks after the initial streptococcal infection. It can have at least weeks. There's a long delay. IgA nephropathy is happening almost at the same time because it's that generation of IgA from the upper respiratory infection that then leads immediately to the nephropathy. With post-streptococcal, even though it's also an upper respiratory infection, or sometimes it can be impetigo, so don't get thrown. If it's a skin infection, can do this too. Streptococcus is streptococcus, right? Whether it's impetigo or whether it's pharyngitis, it doesn't matter. As long as there was exposure to that bug, you're going to get those antibodies, and those antibodies will take some time to lead to the post-streptococcal glomerulonephritis picture. All right? So I want you to notice here the fibrinoid necrosis of the tuft, especially up here. You have this necrotic looking tissue. You have this fibrin, this very dense dark purple staining. And when you look at it under the light microscopy, you can see it, right? You have this crescent, this focal crescent, and this sclerotic necrotic picture, right? So it's not good. Okay, you can see here this fine ribbon dusting, etc. You can see you've got all sorts of mesangial here, subendothelial here. How do I know which is which? Because it's off in the middle of nowhere. That's the mesangium. The deposits here are really along the capillaries, so I'm going to call those subendothelial. And it's not a good picture. And this is just for your interest. You can see that it can get even worse, right? So this is like a worsening of what we saw before. All right. You can see here you have this crescent. This is all crescentic. This is fibrin staining, by the way. So all of this is fibrin. This is all fibrin, and that's important for your step exams to understand that the main component of the crescent is mononuclear cells and fibrin. I'm going to say it again. The main component of the crescent is mononuclear cells and fibrin. So this is sort of like the more mild picture. This is what it can evolve into. And you can see you have this really severe compression of the glomerulus, All right? And you see infiltration of the immune, this really ants, that ants marching in a line. You get that picture, and it's all entering the glomerulus, and it's just not a good. It's not a good look. And if you look here at this tubule, so this you're gonna take my word for it that this is a distal convoluted tubule. The proximal tubules tend to look more juicy and have a more rigid structure. Although this is a disease state, so I could be wrong because it might not be physiologic. The point is this is a tubule, and notice how the tubule is filled with blood. All right. And maybe some hyaline exudate. It could be exudate, it could be blood. The point is, what I'm really trying to draw your attention to is how compressed this glomerular capillary tuft is by this crescent. And this crescent contains mononuclear cells and fibrin. It's very important. All right. So over here we have the anti-glomerular basement membrane disease. So you can see here it's all lighting up on IgG. When you try to fluoresce for and use your anti-IgG antibody, and that'll fluoresce under the electron microscopy, you can see it really just lights up. And it really forms these ribbons. And that linear deposition of it, forming this like fine ribbon, is what confirms anti-GBM disease. Let's say you had this picture over here, and your light microscopy didn't look like that. That's called pauci-immune. It doesn't really look like there's an immune antibody stimulus. Then you have to consider things like granulomatosis with polyangiitis, etc. The ANCA vasculitis. So what causes the crescents? The damage to the capillary wall produces necrotic disease. Red blood cells and fibrinogen enter Bowman space. Focal and necrotizing crescentic disease is often antiglomerular basement membrane or ANCA associated. Kidney failure happens rapidly, and some models say that lymphocytes or leukocytes are what lead to the inflammation, and that activates giant cells and proliferation of the parietal epithelium, and that compression, and that it lays all that fibrin getting laid down, and so this is what it's supposed to normally look like, and what we looked on the other slide does not look like that. The last thing I want to draw your attention to is Alport syndrome. When you see nephrotic picture with with deafness, consider Alport syndrome. It's just a deficit in the type 4 collagen, leads to so normally the glomerular basement membrane is like super intact and kind of clean, for lack of a better word. Notice here it's just all kind of crapped up. All this dark stuff is the glomerular basement membrane. It's not a smooth, continuous layer. It's all crapped up. And what you see over here is a thickened basement membrane. Right? So this is sort of a different process. This is a thickened basement membrane. What you see here is a sort of this is the basket weave. All right, this is the basket weave over here. All right, so we'll have a separate lecture on vascular kidney dysfunction. I know this was a long one, but it really covers almost everything you need to know about the glomerulus and its diseases. Thank you.